So I'll talk to you about the principles of medical management of microbial keratitis, and we'll cover bacterial, fungal as well as parasitic infections. And again, I will begin with this 30-year-old male patient who presented with a small peripheral corneal infection. How are we going to manage this patient? Are you going to treat this patient empirically, or are you going to do microbiology in each and every patient who is presenting to you with this clinical picture? Which antimicrobials are you going to choose for the management of this patient, and what are the different routes of administration? Because over past 15 years we have realized a large number of these patients are not only treated by topical administration but are also given a lot of systemic antibiotics. Are you going to treat this patient also using the same strategy as was used in the previous strategy? So the goals of my presentation during this 15 minutes are going to be giving you pearls of the medical management, give you guidelines when you should refer these patients, and understand some of the pharmacological concepts that helps us decide on the management of these patients. If you look at the basic aims in the management of cases of corneal infection is eradication of microbial agents, and then control of inflammation, and finally achieving preservation of vision as much as you can. And to achieve these goals, what you need to do is to identify the causative agent and start appropriate antimicrobial therapy. And therefore, the identification of microorganism becomes the most crucial step in handling patients of corneal infection. And the previous two talks have really highlighted that although there are certain clinical features which can help you clinch the diagnosis or construct the differential diagnosis, you will have to keep in mind that those classical clinical pictures are not present in each and every patient. And therefore, Dr. Savitri Sharma told you that we must do microbiology workup in these patients. But the question toward microbiology workup comes that you require to have so many gadgets in the lab so as to do the microbiology laboratory test. It is not that easy. And if you go in community and try to understand how many of us are doing microbiology, you will realize that 95% of all patients of corneal ulcer are treated without any microbiology lab work. And this is all because what you need is a well-equipped laboratory, trained staff to handle such small samples, and all tests involve cost and logistics. This is the reason that most ophthalmologists are either not able to afford the cost or are not having access to microbiology laboratory. And the question that often comes to their mind, is it really necessary to treat cases of infiltrative keratitis doing microbiology workup? Many of you have also put the argument that I have treated so many patients without any microbiology workup, and 80% of the patient resolve to treatment. So why should I do microbiology workup? The reason why empirical therapy has been successful in the Western world and also in our clinical practice is a large number of corneal infections were caused by bacteria. And most antibacterial drugs are bactericidal. However, and therefore you get a high proportion of cure. But if you look at the epidemiology in our country, you will realize that nearly 40% of all cases of corneal ulcer are caused by fungi. And toward that, I think one of the tests that you include in your diagnostic armamentarium along with clinical examination and going to help in a big way is light microscopic examination of 10% KOH mount. That will at least help you establish the diagnosis of fungal infection if it turns out to be positive. And you have to keep in mind that KOH has a very high sensitivity and specificity. If you do not see fungal filament on the smear examination and the patient is not having classical clinical features of fungal infection, you can start patient empirical treatment with broad spectrum antibiotic. Mind you, it should be a broad spectrum antibiotic covering both gram positive as well as gram negative spectrum. However, there are certain care points that you must keep in mind when you start treatment empirically. The empirical treatment should be reserved only for non-severe ulcer. They should not be used for severe corneal ulcer, and cases that do not have classical clinical signs of fungal or acanthamoeba infection. The empirical treatment has to be always with broad spectrum antibiotic, and you should not just dispense the medicine and forget about the patient. Rather, all these patients who are treated on empirical therapy must be examined again within 24 to 48 hours to understand the response to empirical therapy. And all severe corneal ulcer cases must be treated based on microbiology. So if you do not have a facility for microbiology, refer them to a center where such facilities exist. So how are you going to manage this patient? As a small peripheral infiltrate, and if you do not have access to microbiology lab, probably the answer is this is a non-severe keratitis having no clinical feature of fungal or acanthamoeba infection, and therefore you can treat probably by empirical way using broad spectrum antibiotic. Whenever you are starting empirical treatment, another question that comes to your mind: should you use fluoroquinolones or fortified antibiotics in the management of these cases? The fortified antibiotics have certain disadvantages. They are not commercially available. You will have to prepare the drop and dispense that. All of these drops have limited shelf life. You will have to discard the drop at the end of 1 month in most of the cases, and preferably at the end of 1 week. They have issues of pH and tonicity. They usually produce lot more toxicity as compared to commercially available fluoroquinolones. Fluoroquinolones, on the other hand, have advantage of being available commercially. Their shelf life is usually long. They do not have issues of pH and tonicity because their safety has already been tested, and they are non-toxic. And this study, which was done way back in 1990, which is known as bacterial keratitis study, proved that fluoroquinolone monotherapy is as effective in eradicating microorganisms in bacterial keratitis as fortified antibiotics. And this was the reason that fluoroquinolones were used with lot of euphoria, both for management of conjunctivitis and keratitis, as well as a systemic therapy for patients of endophthalmitis. And you are seeing that we use this molecule extensively for prophylaxis against endophthalmitis following various surgical procedures. Now, what this euphoria resulted in? Within 5 years, we started seeing emergence of resistant organisms, particularly to first generation fluoroquinolones. There were several reports which were published of resistance or decreased susceptibility, not only for isolates from keratitis, but also from isolates of conjunctivitis and endophthalmitis. This led industry to look for better molecules, and they developed 8-methoxyfluoroquinolone in the form of moxifloxacin and gatifloxacin. They showed that these molecules were having better activity as compared to first generation fluoroquinolone against gram-positive organisms. They were having activities even against organisms which were resistant to first generation fluoroquinolones. These molecules were found to have much better activity even against atypical mycobacteria, were found to be more susceptible or superior activity against quinolone resistant organism, and were found to have much better kill kinetics as compared to other antibacterial agents. Even on in vivo tests, they were found to result in better or improved eradication of bacterial isolates. So the consensus was reached that now we cannot use first generation fluoroquinolone. Can we use gatifloxacin and moxifloxacin as a monotherapy in the management of bacterial keratitis? The American Academy Technology Assessment Committee recommended that monotherapy with moxi and gatifloxacin still can be considered in treatment of non-severe corneal ulcer where the corneal diameters are less than 2 mm in size. However, for severe corneal ulcer, they advocate combination therapy, that is a therapy with drugs effective against gram-positive and gram-negative organisms. And at our center, we use combination of fortified cefazolin, which has a better activity against gram-positive organism, and ciprofloxacin, which still is able to have activity against gram-negative organisms, including Pseudomonas. Which cases you should refer to tertiary eye care center? All severe keratitis cases, all clinically suspected fungal and acanthamoeba infection if you are not able to document them on microbiology workup, and cases which on close observation shows worsening to empirical antibacterial therapy. So all such cases, there is no need for you to modify treatment and retain them with you, but rather refer them early so that their definitive management can be started early, and that will help preserve vision in many of these cases. Another word of caution that antifungal treatment and anti-acanthamoeba treatment should not be started on an empirical basis. Their treatment should be started only when these organisms have been documented either on smear examination or on culture. The reason is that most of these drugs are highly toxic to epithelium, require prolonged treatment, and therefore if you are committing antifungal or anti-acanthamoeba treatment to any patient, you must be ready that these drugs are not going to show clinical resolution over 3 to 6 weeks of treatment. What is the difference in the treatment regimen at primary or secondary level versus tertiary level? At tertiary eye care centers, we always recommend that the treatment should be started based on initial identification of organism, and they should advocate or practice the use of microbiology facilities in the management of each and every case. And all severe ulcer cases should be treated using fortified antibiotic drug. Let us now look at what are the principles to choose the best molecule, because if you look at the pharmacology of antibacterial drug, there are several of these available. They may not be available as ophthalmic suspension, but for systemic administration, several of these molecules are available. What is this drug resistance, and how do we prevent this drug resistance, and how do we identify drug toxicity? If you look at, these are the various antibacterial molecules that are used in the management of corneal infection. For gram-positive organism, you have cefazolin, vancomycin, chloramphenicol. For gram-negative, tobramycin, gentamicin, amikacin, fluoroquinolones, and imipenems. Whenever you are combining antibacterial drug, always remember that you combine drugs which are acting by two different mechanisms. Don't combine drugs which act by the similar mechanism of action. That is one principle that will help you choose combination drugs. Be familiar with terminologies such as minimum inhibitory concentration, minimum bactericidal concentration, and mutant prevention concentration. And this graph will show you why we have to be aware of these terminology. At minimum inhibitory concentration, the organisms are not killed. Their growth is inhibited on the culture media. At minimum bactericidal concentration, the organisms are killed, but those surviving organisms can still develop mutation and drug resistance. Whereas the mutant prevention concentration is one at which there is no possibility of development of resistance. And your target is that you should have tissue concentrations which are well above the mutant prevention. And if you look at the pharmacodynamics of any drug, you will realize they cross the MPC level, but then the concentration start declining, and the next administration of drug should be done at this point, because if you allow the concentration to dip down, the organisms are likely to develop resistance, and they can then transfer resistance by variety of mechanism, and you are going to contribute to expansion of drug resistant molecules. So some of the precautions that you have to take to prevent drug resistance are: use antibiotics for appropriate indication. Don't just use indiscriminately. The antibiotics are most effective in the treatment of acute infection and not for chronic infections. For surgical prophylaxis, use that for short period of time. Don't prolong your surgical prophylaxis for week, 10 days or 2 weeks. Number 2, dose appropriately. There is no need to treat cases of corneal infection using 2 times doses or 3 times doses. They have to be used in doses where the concentration can be maintained above the mutant prevention level. Number 3, don't taper antibiotic. Antibiotics are not meant to be tapered. They must be stopped abruptly. because it is the tapering of antibiotic that is responsible for development of drug resistance. Use drugs that attain the best tissue levels. There is no need to use drugs which do not attain high concentration. There are certain drugs which have very poor penetration into the corneal tissue. There is no point in using these drugs in the management of corneal infection. And always be familiar that all the drugs that are used in ophthalmology can produce toxicity, either because of their inherent property or because of the preservative that they contain. And part of the reason that ulcer can continue to remain is the presence of drug toxicity. So always be watchful of drug toxicity, and whenever you see signs of drug toxicity, stop drug for a couple of days, assess the response, and if you are seeing resolution on discontinuing antibiotic, that is a sure sign of that your patient is suffering from drug toxicity. Let me take you to the management of fungal infections. There are a variety of antifungal drugs that are available. However, commercially very few antifungal drugs are available. Among the topical drops that are commonly used in the management of fungal infection are natamycin and amphotericin B. Fluconazole and itraconazole are also available as topical suspension, and we do not have any flucytosine available in the market. In addition to topical antifungal therapy, in severe fungal keratitis, you can give systemic therapy either using ketoconazole as 200 mg twice a day oral doses or itraconazole 100 mg twice a day. You will realize that most of these antifungal drugs are fungistatic in nature, have narrow spectrum of activity. Some molecules are effective against fusarium, others are against aspergillus, while some are effective only against candida or yeast. All of these drugs have poor penetration through intact corneal epithelium, and on prolonged administration, because they are available as suspension, they produce toxicity on cornea and conjunctiva. One thing that you have to remember, that none of those molecules that I discussed are superior to each other. Number two, the concurrent use of antifungal drugs does not offer any advantage. There is no point in combining natamycin with itraconazole or natamycin with fluconazole. You do not get much advantage. Rather, use them sequentially. If the patient is not responding to natamycin and you want to still continue antifungal therapy, choose itraconazole. Choose fluconazole depending on the nature of isolates that you have in your patient. There is some role of epithelial debridement, and epithelial debridement facilitate penetration of drug. However, a more recent study published from Madurai found that the patients who had epithelial debridement had poor visual acuity after resolution of corneal infection, and this has started having a debate among ophthalmologists, particularly those who deal with corneal infection, as to we should investigate the role of epithelial debridement more closely in patients of corneal ulcer. Whatever you do with the existing antifungal therapy, 30 to 40% of the patients are likely or unlikely to respond to medical treatment. And this is particularly likely to happen if the ulcer size is more than 14 millimeter square, if your case is having hypopion, or in cases where the infection is caused by aspergillus. Some of the newer antifungal drugs that are commonly talked and are now being in the publication are voriconazole and echinocandidine group of drugs. Both of these group of drugs are water soluble and act by inhibiting synthesis of ergosterol. They have a broad spectrum of activity on in vitro antimicrobial susceptibility. There are no issues of toxicity, including retinal toxicity on intravitreal injection, and very mild or no systemic toxicity on systemic administration. They have very good bioavailability in inflamed and uninflamed eyes, and in a review of literature by Hari Prasad and their group, it was found that this is probably the best molecule in the management of fungal corneal infection. However, a more recent randomized controlled trial comparing natamycin and voriconazole in the treatment of filamentous fungal keratitis found no difference between natamycin and voriconazole. So probably we are reaching to the point where that initial hype is going to be viewed with suspicion as far as voriconazole is concerned. How do we handle the poor penetration issue of antifungal drugs? And particularly in the management of deep keratitis, where the infiltrates have already reached into the deeper can we improve the ocular penetration of the molecule? Probably some of the modes that have been tried are iontophoresis, intracameral injection of both amphotericin B as well as voriconazole, and more recently intracorneal injection of voriconazole in these cases. And the paper published by Dr. Namrata Sharma in 2011 clearly shows that probably these are the options that are available to you in recalcitrant cases of fungal keratitis. However, you should remember that some of these patients may require multiple injections and may not even respond to this mode of treatment. How about acanthamoeba infection? There are several challenges in the treatment of acanthamoeba keratitis because none of the drugs that are proven to be effective in the management of these cases are available in our country or in any country. Drugs are not available commercially and drugs are highly toxic. Some of the facts that you will have to keep in mind: trophozoites are highly susceptible but cysts are highly resistant. Neomycin is ineffective and should not be used in the management of this infection. Most antifungal agents are shown to be effective on in vitro tests, but on clinical trials were found to be ineffective, and they also should not be used indiscriminately in the treatment of this infection. One must remember that most of the anti-acanthamoeba drugs need to be administered for a long period of time for eradication of infection. The primary or the mainstay of treatment is bigonides, that is PHMB and chlorhexidine, but these molecules can be combined with diamidines, that is propamidine, isethionate and hexamidine. As I told you that the treatment duration is usually prolonged and therefore you have to be aware of signs of drug toxicity. What is the role of corticosteroid? Probably controversial, particularly in patients who present to you early. However, there are certain indications in which corticosteroid need to be administered and have some role even in patients of acanthamoeba, and these cases are severe infections, indolent ulcers, and patients who are presenting to you with severe inflammation. We give corticosteroid in patients who present to us with severe pain and deep vascularization, which is progressive in nature, as well as patients who present to us with the scleritis. Some precautions for corticosteroid: do not commence until 2 weeks of therapy with bigonides has been in place. Continue anti-amoebic therapy as long as patient is receiving corticosteroid therapy and even after discontinuation of corticosteroid. And if the eye has been free of inflammation after discontinuation of corticosteroid, you can consider the patient has been cured of acanthamoeba infection. In addition to these antimicrobial treatment, you need to give cycloplegic agent, analgesics and anti-glaucoma drugs based on the necessity of patient. And as I told you, for control of inflammation, adjuvant topical corticosteroid therapy has controversial, and even in bacterial keratitis has not been shown to have any superiority. You need to at times give doxycycline or other metalloprotease inhibitor drugs to prevent tissue destruction. To conclude, a good clinical examination coupled with 10% potassium hydroxide preparation will go a long way in appropriate initiation of therapy in patient of corneal infection. You must logically choose antimicrobial agent so as to prevent toxicity, and good understanding of pharmacology is going to be a very important tool for you to choose the best molecule, continue it for appropriate time, take care of toxicity as well as drug resistance. Thank you very much for your kind attention.